mode.
Good afternoon, everyone. I think it's actually throughout the entire country afternoon now. So on behalf of Fight Colorectal Cancer, I'm Andy Dwyer with a joint appointment at the University of Colorado Cancer Center and the School of Public Health. Welcome you all to a chatinar, as we're calling it today, with Dr. Edith Mitchell to talk about diversity in clinical trials, opportunities in clinical trials, and hearing a bit about some potential as we move forward in the era of science and health discovery to improve patient care. So next slide. Just as a quick reminder for those who are interested in listening to today's broadcast and our meeting presentation, to visit us at fightcolorectalcancer.org/webinars, where you'll find this discussion as well as previous webinars in the slide decks for review at your convenience. After the webinar, we would like you to send out, well, we will always send out a brief survey, and we'd love those responses from all of you. And a little new addition, instead of just the blue star pin, I should say instead of, we are doing the I Heart Booty bracelet that has been wildly popular. So again, evaluation means I Heart Booty bracelet. So we're very excited about evaluation and the bracelet. So make sure and give us some feedback, because we'd really like to hear from all of you about information, today's webinar and satisfaction, as well as information about future topics and interest areas. Just as a reminder today, as we hear from Dr. Mitchell, that if you have questions during the discussion, that at the right side of your screen, you will notice a chat feature, and we would ask you to key in real-time questions so that Sharon Worrell can help facilitate the discussion and the Q&A portion with Dr. Mitchell after the at the close of our chatinar. Follow us along at Twitter, hashtag #CRC webinar, and so just making sure that, of course, we have a large social media presence, and so get updates about timely information about today's webinar, as well as we do this Twitter follow throughout all of our webinars going forward. Next slide. Just a quick reminder that Fight Colorectal Cancer has a variety of resources for colorectal cancer survivors for prevention, as well as for survivorship, treatment, caregivers, and medical providers. So Updated Guide in the Fight is now available on our website, as well as our Tabooty podcast series as well. So check us out at fightcrc.com for more of these resources and information. Next slide. All right, just a quick disclaimer before we get into today's presentation that Fight Colorectal Cancer is here to provide general information and support. In no way does the information presented today or by Fight CRC ever replace direct medical care or information or advice from primary care, oncology, or other healthcare provider. And as, of course, a reminder that at any time that if there's any emergency during a health issue, please call 911. And of course, we never recommend or endorse any specific physician's product or treatments for any condition. Next slide. So I'm going to pass over the mic here in just a moment to Dr. Edith Mitchell, who I'm very excited that we have presenting to us today. Dr. Mitchell has been a longtime supporter of Fight Colorectal Cancer, as well as a number of cancer organizations, and we're really excited that she's part of our team. She leads up the gastrointestinal malignancy department as the director of diversity for Jefferson Cancer Center in Philadelphia, and has done a lot of work with helping leading initiatives for health disparities, as well as helping really make sure that our work is relevant and timely with Fight CRC. I'm also very excited because Dr. Mitchell has been very involved in the Moonshot program and is actually going to share a little bit about her leadership with that initiative, as well as other pieces of the work that she's doing that really have nice implications for clinical trials and for the advancement of science, as well as, again, with the name being outcomes and improved treatment for patients. So with that, I'm going to go ahead and turn it over to Dr. Mitchell to lead us through today's discussion. Dr. Mitchell?
Well, thank you very much, and it is my privilege to be with you this afternoon to discuss clinical trial. I have participated in the design of clinical trials as well as implementation for many, many years. and being able to see outcomes and improved survival based on these clinical trials is actually true and rewarding. So thank you for the invitation to speak today. And at the end of the program, we will have time for questions and answers. I call this a chat because there is so much information on clinical trials that I try to talk about it in a conversational manner, and consequently talking about the clinical trials. So let's start with what are clinical trials and why do people participate? Well, clinical trials are a part of clinical research, and it is how we design plans for improvement in both clinical care as well as survival and other outcomes. For any medication that has been approved by the FDA in this country, there has been a clinical trial, and the results of clinical trials related to each medication and each process are available not only to physicians, but also to patients. So clinical trials is really designing a new way on how we can either prevent disease, detect disease or diagnose diseases, or treat the diseases. There are a number of treatments that are available, and not only are clinical trials affected for medications, but also devices and surgical procedures. Any process that tries to improve the care of patients by evaluating a new procedure. So that is clinical trials. Now, clinical trials also can be designed to evaluate how we improve the quality of life for patients. So, for example, there are survivorship clinical trials. There are clinical trials designed to improve management of pain, management of nutrition, and other processes that especially affect cancer patients. So for cancer research, this not only involves medications and treatments, but also quality of life measures, so making life better for the cancer patient. Individuals participating in clinical trials must volunteer to be in the clinical trial, and I will explain more about receiving information regarding the clinical trial. So how do you decide what clinical trial to implement or what clinical trial to do? Well, it usually starts with an idea. That idea could be a new procedure or a new medication in the laboratory that has been tested in animals frequently. But overall, the clinical trial is designed around an experimental treatment and how it might improve the life of cancer patients. This treatment designs the process as well as the risk and potential effectiveness. All clinical trials are designed around a protocol, and the protocol is the method or procedure that is utilized to perform either the medication, administer the medication, or perform the procedure. And the protocol ensures that every patient is treated in the same manner receives the same dose of medication or the appropriate dose for their body size, and therefore this ensures continuity in treatment from one patient to the next. The protocol defines who is eligible to participate in the trial. It also details the tests, the procedures, the medications, and dosages. How long will patients be treated on that protocol? And it ensures continuity and uniformity from one patient to the next so that we will know an answer at the end of the clinical trial. All physicians and providers participating in a clinical trial and treating patients on clinical trials must, and I say must, agree to adhere to the protocol. And again, that ensures uniformity, continuity, and the assurance that all patients are treated in the same manner. There is IRB review. An IRB review involves a group of individuals who are not associated with the protocol, but who review it and who ensure that it is monitored closely. The IRB assures that patients are protected, and therefore one does not have to worry about instances where a physician or group of physicians can do whatever they want. So IRB is the compliance part of the clinical trial, and then there are the sponsors who give financial support for the study. For many cancer studies, there are private companies, pharmaceutical companies, or those companies making equipment may support the study. The National Cancer Institute is a major supporter of cancer clinical trials in this country. There are 69 National Cancer Institute supported institutions or cancer centers in the country. There are also cooperative groups that are supported by the National Cancer Institute, as well as individual researchers. So the National Cancer Institute is a major sponsor of cancer research in this country. Now, once the protocol has been designed, it's written, the participant physicians are assigned to the protocol, a volunteer for the protocol. There is the design of the informed consent. The informed consent is a written document where the physician or representative of the physician discusses with the patient. Every single protocol must have a consent form, and every consent form must be designed properly with the appropriate information. The IRB assures that there is compliance with standards, and this consent form must not only be discussed with the patient, but you should have a copy of that consent form. And the consent form describes the plan of the clinical trial, what is the potential benefit for the patient, and what can the patient expect, both in terms of side effects, what does the medicine do to the patient. The consent form also describes how frequently the patient comes in for the procedure of drug administration or other components. It also identifies how many days the patient has to come in for laboratory tests. What are these laboratory tests, and what do they mean? So the protocol describes the entire amount that happens to the patient. The informed consent describes what is going to happen and then the expectations, both in terms of potential treatment outcomes and benefits, as well as potential side effects. Now, with the consent form, once a patient signs a consent form, it is not written in concrete. And by that I mean, if an individual decides to go into a clinical trial, and then after talking to other individuals or to their physician or to anyone, and they decide that they no longer want to participate in the clinical trial, you, as the patient, have the right to withdraw consent. And by withdrawing consent, that means that you are refusing further treatments or testing, and therefore, if you withdraw consent, you cannot continue participation in the study. So informed consent is a method of making sure that the patient and the patient's family or other individual who is supporting that patient understands what will happen with the clinical trial, what is the treatment, what are the expectations of the treatment, what are the potential side effects of the treatment, and the fact that the patient can withdraw consent at a different time. There are types of clinical trials, and the type of clinical trial is related to the plan of administration of the protocol. So there are some natural history protocols that simply want to know what has happened to the patient and how about the disease, what age did they develop the disease. These are called natural history studies. And with this, we can understand for colon cancer, for example, what is the average age of patients at the time that they develop colon cancer. And with that, we know now that the median age at the time of diagnosis of colon cancer in the United States is 72 years. Some individual will develop colon cancer earlier than 72 years. Others will develop colon cancer after 72 years. But the median age at the time of diagnosis is 72 years. There are prevention trials. Now, with prevention trials, one is trying to prevent colon cancer. And many of the colonoscopy clinical trials were prevention trials. And the idea was, if you do a colonoscopy and you resect a polyp, that polyp can no longer develop into a cancer. And does that improve the overall outcome of patients? And at this time, from all of the clinical trials that have been conducted with colonoscopy, as well as other diagnostic procedures, we know that prevention trials can save lives in colorectal cancer. It prevents the disease from happening by resecting the polyp. There are screening trials that are used to detect other conditions or diseases that the patients may have. There are diagnostic trials. For example, CT scans are diagnostic trials, and we usually do CT scans on everyone who has been diagnosed with colon cancer. And that helps us know the extent of disease. Is there spread to lymph nodes or to other organs such as the liver or the lungs at the time of diagnosis? Then there are treatment trials. And treatment trials are related to improving the overall survival of patients. I can remember when there was only treatment available for colon cancer with 5-FU and leucovorin. There was no oxaliplatin, there was no irinotecan or FOLFIRI or FOLFOX. And the first drug to be approved by the FDA for colon cancer was irinotecan in 1996. So we had another drug in addition to 5-FU and leucovorin. So those are treatment trials. Now, every patient knows about FOLFOX and FOLFIRI, bevacizumab, cetuximab, panitumumab, and others. All of these drugs became available to patients through clinical trials, and I am very appreciative to the patients who participated in those clinical trials because it has allowed lots of other patients to survive colon cancer and to live longer. We do the trials in phases. So you may hear of phase 1 trials. And with phase 1 trials, these are the early trials with the drug to determine what are the side effects of the drugs. These are usually small studies. The phase 2 studies usually are designed to evaluate and determine effectiveness and further safety of the drugs. They may be used alone, or they may be combined with other drugs in phase 2 trials. For phase 3 trials, we evaluate usually 2 or more treatments to see which one is best. So, for example, for colon cancer, years ago, 5-FU leucovorin was the standard of treatment after surgery. There was a study done, a clinical trial, evaluating the standard treatment, which was 5-FU leucovorin, against the new treatment, which was oxaliplatin with 5-FU leucovorin, or FOLFOX. And FOLFOX was superior in overall outcomes, and thus FOLFOX became the standard treatment for colon cancer after surgical resection. So that's a phase 3 trial. And phase 4 trials are conducted after the drug is approved by the FDA, and therefore more information is needed about the drug, side effects, benefits, and how to use the drugs. So those are the 4 phases of clinical trials: phase 1, phase 2, phase 3, and phase 4. Now, another important concept to understand is placebo. And many people are worried about a placebo, but it is very important to determine effectiveness of drugs. For example, the drug bevacizumab. Once we understood FOLFOX and FOLFIRI, those clinical trials to define the effectiveness of bevacizumab or Avastin were conducted in a manner every patient received the standard treatment. So that would have been a FOLFOX or a FOLFIRI. Half the patients would receive the new drug, bevacizumab, and half the patients would receive the placebo. And that is to determine, can we add a new drug to a standard treatment and improve overall outcomes? And I explain it to patients by saying it's standard treatment, or the other is standard plus. So some patients are going to get standard plus, and other patients will receive standard plus placebo, but every single patient receives the standard of care treatment. And then there is randomization. Randomization simply means that your doctor cannot select the treatment in a phase 3 study. It is done by a method where the patient doesn't decide the treatment, the physician or provider doesn't decide on the treatment, and therefore it is non-biased. So it's called randomization. And after randomization, your physician will then describe to you which of the medications you will receive. That is sometimes referred to as which arm will you receive. So there are two or more arms or two or more treatments, and once that randomization occurs, it is in an unbiased manner. And once that occurs, your doctor or provider will let you know which arm you will receive. So potential benefits. I've mentioned that the protocols are designed to give the patient the best opportunity for treatment success. We also want to make sure that potential risk or potential side effects are minimized. So we try very hard to decrease the unpleasant or the serious side effects. Some individuals call these toxicities. So what should a patient do if they're offered a clinical trial? Well, I'd like to start a little bit ahead of that and say that once individuals know that there is a diagnosis of cancer, start looking for clinical trials. Start looking for how you can get better treatment and potentially new treatments that have the effect of potentially being more effective. So what do you ask the doctors? Well, I think there's some simple questions you can ask. What is the purpose of the study? Why do people think it should be more effective? Why do researchers believe the study? Who will actually pay for the study? Is it an NCI, that's the National Cancer Institute supported study? Or is there a pharmaceutical company that pays for the study? What is the approval process? Where is the IRB? How long will the study last? And what are the patient responsibilities? What are the possible risks? What does it mean by participation in care? How many times does the patient have to come to the center for evaluation or to get tests? How many CAT scans will the patient have to undergo? And will the insurance cover the CAT scans or other procedures? And what are the costs that the patient has to pay out of pocket? So participation in care, very important. And you should always discuss the clinical trial with your main primary care physician, because the primary care physician, number one, should know about the clinical trial, but two, may be able to give you helpful information. So always discuss it with your doctor. You also want to know, where will I receive this treatment? Will it all occur at a downtown hospital, or is there a hospital near where the patient lives, where they may be able to get the same treatment? There are personal issues. How is this clinical trial going to affect my daily life? You also might ask, well, can I speak with someone who has been through this trial? Or better yet, doctor, how many patients have you treated on this clinical trial? So that you know, and you are able to get that information. How are you protected? I mentioned the IRB and ethical guidelines. There are those methods with the IRB, and your doctor can give you their protection documentation from the Office of Human Research. So there is actually an Office of Human Research in Washington that is set up particularly to provide care and to provide protection of patients. You can also ask, how does the outcome of clinical research make a difference in my cancer process. So how will it potentially make a difference in colon cancer? So I'd like to start with the patient who is recently diagnosed with cancer. How do you get into clinical trials? Well, the first thing you want to do is have your doctor tell you exactly what kind of cancer do I have. Now, why is that important? Well, in discussing colon cancer, there are multiple types of colon cancer, and the treatment may differ or vary based on the type. So ask your doctor, what kind of cancer does the patient have? Is there a pathology report? And every single patient with cancer should get a copy of the pathology report that tells the patient what kind of cancer that they have. So every single colon cancer patient should have a copy of their pathology report. Where is the cancer located? Has the cancer spread to any other organ or beyond where it started? For example, has the cancer spread to the liver or to the lungs or other places? What is the cancer stage? Every patient should know the stage of their cancer and what stage actually means. Staging, for example, stomach cancer is different from colon cancer. Anal cancer is different from rectal cancer. So you need to know the stage. How does the stage of cancer affect treatment and long-term outcomes and prognosis? So once you know the stage, you should ask the physician, if they don't tell you, how is the stage going to affect your prognosis? What are the chances of survival with this cancer? Ask the doctor, how much experience do you have in treating this type of cancer? How many patients have you treated? You can also ask to speak to other patients who've gone through that treatment. Will you need other tests before you decide on a treatment? What are my treatment choices? Is this standard care or is it a clinical trial? What treatment do you recommend and why? Why do you recommend a specific clinical trial if that is recommended? You can also ask, are there other members of my family at risk for developing this cancer? Should I get genetic testing? Should I recommend that other family members undergo evaluation for genetic testing? Should I get a second opinion? And with second opinions, I think it's always important for the physician to feel confident that they have given the patient the best information, and therefore a second opinion is not a risk. So ask for a second opinion. You can also ask for what are the out-of-pocket expenses for participating in this clinical trial, and what services does the center provide to help patients stay in the clinical trials? For example, is there a transportation service? Is there a lodging service? Will the center pay for bus fare or taxi fare? So ask those questions. And ask about the clinical trial. Was it designed for that particular treatment? How is it designed? Is it a National Cancer Institute trial? And the one thing that everybody can ask is this trial on clinicaltrials.gov? The National Cancer Institute has a site. It is called clinicaltrials.gov. And most clinical trials, at least in the United States, most good clinical trials are listed in clinicaltrials.gov. So remember, clinicaltrials.gov, and you can go onto that website and read about it. You also want to ask, what if I stop participating in a clinical trial? And that's very important because some clinical trials provide medications for the patient. some provide coverage for various scans, and you will want to know, are these covered or are they not covered? And does your insurance, your medical insurance, cover these procedures and scans? An area that many people forget about in terms of cancer treatment is, after the treatment, what are the chances that this cancer is coming back, and will I be able to have children after this treatment? So for some procedures, yes, individuals can have treatment, can have children. For other cancers and treatments, the individual is less likely to be able to have a child. So you want to ask about that and ask if there are any procedures you can do to protect the patient so that after treatment they can either save sperm for men or freeze ovaries for women so that there is a likelihood of fathering a child or a woman having a child. Again, you want to know, does your insurance cover it? How long will the treatment last? What does it involve? Where will the treatment be done? What are the side effects? All of these are questions that the patient can ask. How will treatment affect my daily activities? Can I still go to work? Am I going to be too sick to go to work? Will there be any scars left after the treatment? What do I have to do to get ready for treatment? Will I need transfusions? What do I eat? All of that is important. How will we know, doctor, that the treatment is working? How about side effects? What can we do to prevent some side effects or to manage them? How can you reach the doctor in charge of the clinical trial after hours? So nighttime, when most cancer centers are not open, holidays, weekends, you want to know, if I need to talk with someone, who do I call and how do I reach them after hours, nights and weekends and holidays? I mentioned nutrition and eating. What do I need to eat? What are the limits on what I can do? Can I exercise? If I am overwhelmed by having cancer and all the treatment and all the information, is there a mental health professional who might assist me? Do you have them available? Are they a part of your team? What kinds of things should you watch for on treatment? And then once the treatment is over, again, are there limits on what I can do? Can I go to work? What kind of exercise should I do? What kind of follow-up? Are there any medications that I should not take? For example, aspirin with some medications. So you want to ask those questions. And basically, participating in clinical trials offers the potential benefit of better outcomes. And that's how we have made many advances in colon cancer treatment over the years. And we will continue to do cancer clinical trials. For colon cancer, when I was a resident in training, the median survival of patients with metastatic colon cancer was 6 months. And the elucidation of the fact that leucovorin enhanced the effect of 5-FU was a tremendous clinical trial outcome. And there have been many more since then, such that the median survival of patients, even with widely metastatic colon cancer now, exceeds 3 years. And for many patients, they can be cured of the disease, even if there are metastases at the time of diagnosis. And this has all transpired through the development of good clinical trials that advanced our knowledge in colon cancer and transformed the entire process. So now I'd like to use the last few minutes to talk about Moonshot. Moonshot is a new cancer research program that is undergoing development at this time. President Barack Obama discussed it at his State of the Union address on the 12th of January, 2016, and he indicated that Vice President Biden would be the chair of this initiative. And Vice President Biden spoke at the AACR, a research meeting last week, and he indicated that we have to improve our data sharing from clinical trials by making publications and results of the trials more available, by recruiting more patients into clinical trials, by streamlining the cancer research grant process, and incentivizing the verification of studies so that we can ultimately win the war on cancer. The Obama administration plans to add more than $800 million to the National Cancer Institute budget for developing these new processes and new plans. And the commitment is that we will eliminate the barriers that get in your way, that get in the way of science, research, and development. And those are direct quotes from Vice President Biden. He believes that providing research to patients is one of the greatest barriers to cancer research. And he says that the research will be to develop methods where we can get more patients on clinical trials. It is well recognized that for all cancer clinical trials, only about 4% of patients in this country with cancer go on to clinical trials. So the idea is to increase the number of patients going on to clinical trials. I am very pleased to have been named to the 28-person panel. It is my privilege to represent my patients, but not only my patients, but to each of you, and especially those that are members of the group Fight Colorectal Cancer, and to those of you who are on the program today. So with that, I'd like to conclude. It is my privilege to speak with you about clinical trials. I encourage participation in clinical trials and finding out as much information as possible regarding the clinical trials. So with that, I will end now, and I'm happy to answer questions.
Great, thank you, Dr. Mitchell. We did have a couple questions come in. This is Sharon Worrell. I'm going to go ahead and relay some questions to you.
Okay, Sharon, thank you.
Great. So we know that health disparities exist within the healthcare system, and that clinical trials don't necessarily reflect the diversity of America in general. Can you expand on this and why that might be a problem?
Well, it's a very important question and a very important concept. It is really important that individuals who go onto clinical trials, and when we finish a clinical trial, that the results of that trial are known, and that the results of the trial are reflected in the population of individuals who are expected to experience that cancer. So for colon cancer, for example, there are populations in this country who have a higher incidence of colon cancer. One of those groups is the African American population. African Americans develop colon cancer at a younger age, have more aggressive disease, and die of the disease much earlier and much more frequently than other racial or ethnic groups. So a lot of research is ongoing to try and understand why, but not only to understand why, to fix it. And that is because if we don't fix colon cancer in the African American population and other minority populations, and the number of those minorities is increasing in numbers and percentage in the population, we're not going to cure colon cancer. It is estimated that by 2030, minority populations in this country will be the majority, so increasing numbers. So therefore, I think it's really important to understand colon cancer in African Americans. Another group that we don't think about very much is the young patient with colon cancer. For most individuals, the guidelines recommend screening for the average individual at age 50. But what we know is that over the last decade, colon cancer in individuals younger than 50 has increased tremendously and is increasing at the rate of 2% per year. More young patients. I can't tell you how many young patients in their 20s and 30s that I see with colon cancer. In fact, the youngest patient that I treated was 16 years old. So therefore, it's very important that we do research in groups of individuals where we know there is an increase either in incidence or death or mortality rate or both. And two of the critical issues now are colon cancer in African Americans and colon cancer in young patients.
Great, thank you. I have one more question here.
Okay.
Can a clinical trial be the initial course of therapy?
Yes. So you can ask about clinical trials as the initial course of therapy. For example, robotic surgery. Years ago, after undergoing either surgery for rectal cancer or for colon cancer, the patient ended up with a scar that extended from above the belly button all the way down to the pelvis. Now, with clinical trials, most of the patients undergo robotic resection, and there is just two little 1-inch incisions in the middle of the abdomen and one incision that's a little more than 1 inch in the bottom of the lower abdomen. Now, what that allows for is that, number one, we know that robotic surgery is just as good as keeping people alive as the old mechanism where we open the entire abdomen. But also, the robotic surgery allows patients to leave the hospital earlier. So that's one advantage of surgical clinical trials in colon and rectal cancer. Another is related to giving FOLFOX immediately after surgery. That's an important clinical trial that has shown benefit. And also, as the first line of treatment with metastatic disease, giving either FOLFIRI or FOLFOX, either with bevacizumab or Avastin is another name for it, or giving it with cetuximab or panitumumab. So yes, the clinical trial can be the first order of business or the first method of treatment when the patient is diagnosed with either cancer that is removable by surgery or widespread metastatic disease that is treatable by drug therapy. And the drug therapy clinical trial can be the first line of therapy and has been shown to have a positive effect on what we call relapse-free survival, progression-free survival, meaning that the tumor is not growing, or on overall survival, meaning how long the patient is going to live. Other questions?
Yeah, we have one more here, Dr. Mitchell. How would you encourage a patient who might be fearful of clinical trials? What might you tell that patient to encourage them to seek out or learn more about clinical trials?
Well, I think all patients should go to their doctors first, and that doctor should include the primary care physician, but might involve the surgeon and the oncologist or others. I think every patient should have someone go with them to hear about the clinical trial. That other person can be a spouse or a child. It could be a friend, but someone who can help with itemizing the information that is given during the interview, but also to make sure that you have a notebook and you write down everything in the notebook. So whoever accompanies the patient for an appointment where you're going to get information, everybody writes in this notebook so that you have all of the information written down and you can review it when you go back home. So have a friend, and that friend can be a family member or a non-family member, but somebody you trust and someone who will take accurate notes and give accurate information.
Great. Thank you so much, Dr. Mitchell. Let's see. How are we doing on time?
We have 5 more minutes.
Great. Okay, here we go. We have one more. How can patient advocates become a part of the Moonshot program?
Great question. We do have some patient advocates on the Moonshot program, and we have working groups where there will be patients and patient advocates, so that we have incorporated ideas of all of the stakeholders in cancer research and cancer care. There is a website that you can go to on the NCI. It's on the main NCI website, and if you query Moonshot, you can get to that, where people can suggest ideas. And I encourage everybody to find out who the people are on the Moonshot team and give us information. So you can send me an email or put the suggestion directly onto the website. You can give other individuals on the team suggestions. So we're all working to get as much information as we can from as many people as we can. We probably have time for one more question, Andrew.
Okay, yeah, now we're starting to get a whole bunch in, so let's see. So I have a question here specifically related to minority groups. What have you heard from these groups, from minority groups, as a reason why there's lack of participation in these clinical trials?
Oh, that's another hour lecture. There have been many reasons defined. They vary for each group. We also have an entity called cultural competence, and what you will find is that many providers and physicians make assumptions about the lack of participation in clinical trials and won't even invite the minority patients to participate. And there have been research publications in the literature on this where patients were followed. One of the most important is at the Massachusetts General Hospital in Boston, and patients with lung cancer, for example, were not offered the same treatment for black patients as they did for white patients. So there are a number of barriers, both in terms of patients, but also in terms of physicians. So we've got to enhance our cultural competence and make sure that material is presented to individuals in the correct manner. It is important to make sure that we are offering patients the right clinical trial and that we offer clinical trials to everyone. When I speak with my minority patients, they ask the same questions as the majority patients do. There's also Tuskegee, lack of trust in institutions, lack of trust in the clinical trials process. So the reason that members of minority communities do not participate in clinical trials are multifactorial, both in terms of the community, but also physicians, researchers, and providers must assume some of the responsibility in making sure that the clinical trials are appropriate for that population, that the written consent is appropriate for that population. The form is another area of discussion regarding clinical trials, and for many clinical trials, the consent form is not appropriately written for certain minority groups. So we've got a long way to go to make sure that the clinical trials are available for the right people with the disease. So research continues on how we can improve on the process.
Great. Thank you so much, Dr. Mitchell, for your time and for answering all these questions. Very, very helpful, very informative. So we already went through the questions here. And also I want to send a thank you to the Fright CRC team, Michael, Danielle, Andrew, Andy, for all your help putting all this together.
Okay. I thank everyone for organizing the programs and organizing programs like this for our patients. And thanks for all the patients and their families and advocates that spent the time with us today.
Wonderful. Thank you so much, Dr. Mitchell, and thank you for all you listeners. We look forward to more webinars in the future, and thanks for all the great discussion.
It's always a pleasure. Thank you.
All right. Bye-bye.
Goodbye.